Hey everyone, my name is Diana Isaacs. I'm an endocrine pharmacist and also the director of education and training in diabetes technology at Cleveland Clinic. And I am joined with Natalie.
Hi, everyone. My name is Natalie Bellini. I'm an assistant professor of medicine at Case Western Reserve University and the program director for diabetes technology at University Hospitals in Cleveland, Ohio.
So you may know us because we are the co-hosts of Diabetes Dialogue, Technology, Therapeutics, and Real World Perspectives. But today we are here for Diabetes Sisters to talk about inhaled insulin. So if you haven't heard or you're not familiar, inhaled insulin is actually the fastest insulin that there is. And why that's good is because physiologic insulin. So, insulin in people with totally functioning pancreases that don't have diabetes works really quickly. So, we ideally would want an insulin that also works that quickly, that you don't have to worry about pre-bolusing and taking so far in advance of your meal. Or if you have a high blood sugar, that you can bring it down quickly. So, Natalie, I'm going to turn it over to you. What are some kind of cases of when you use inhaled insulin?
So I love to offer inhaled insulin as an option to people. There's a couple of different kind of scenarios that pop out instantaneously. People who will say things like, I will never do an injection at work. Okay, but you really want to eat what everyone else is eating at work. And sometimes you order to go food and sometimes right? And sometimes they bring in, it's like sandwich, pizza, whatever kind of day. That's a high carb meal. You need insulin. Would you be willing to, use an inhaled insulin that comes in an inhaler like this that you could carry in your pocket or your purse? So I offer it there. I offer it for people who need a break, who are using a pump or and just say, I want the summer off, or I want to try something different, or someone who's really challenged even with scar tissue and pumping. And this is an alternative to all of that. So, and that's just the tip of the iceberg. I even have some people using AID who, instead of using bolus insulin, because even bolus insulin from an AID system doesn't, still plays some catch up, right? That they use this inhaled insulin on top of that instead of bolusing.
Yeah, I think those are all great use cases. Also, I've got several patients that sometimes just want to take a pump break. They don't want to have something attached to their body all of the time, or they just feel like their sites are starting to just feel uncomfortable, or maybe not absorbing as well over time, and they want that pump break. And actually, there was a recent study called the Inhale 3 where they actually randomized people. They took people that were previously on pumps, on AID systems, and randomized some of them to inhaled insulin versus some of them continued their current therapy. And they showed that when you use inhaled insulin, you can get as good of management actually as an AID system. So it's definitely, I think it's a great option that is so underutilized, either because people don't know about it or they're not being offered it. And so we just want to get the word out there that, hey, this is an option for people.
I absolutely agree. And one of the things is it's a little bit different than insulin that you inject or infuse, right? So the smallest increment available is a 4-unit cartridge. And we go back and forth about this because the FDA said this is what a 4-unit cartridge is, but it doesn't act as 4 units. And so that's where people start to go, "What? What do you mean?" So I could never take 4 units at a meal. Well, it really acts as 2 and maybe even less for some people. So I think that when we as clinicians start talking to people, we need to remember that lots of us, even myself, who's a pretty small person, takes at least a couple of units at a meal, right? So I can use those 4-unit cartridges without a problem, because they're not really absorbing as 4. So the dosing does become a little different, and I think the hesitation with clinicians may be that the clinician doesn't understand that. And so the clinician doesn't offer it because they look at you or I and say, Diana, you couldn't take 4 units at a meal. So I think that might be part of it.
That's
Um,
a really good point because actually, now, so when you look at like kind of the dosing conversion, initially it was like, well, if you're on 1 to 4 units of fast acting, start with 4 units of inhaled. But actually, the more recent data shows that most people end up needing about 3 times as much as their injectable dose. And so, with that in mind, I think then it sets realistic expectations for both the clinician and the patient that, hey, you're going to end up needing a little bit more. I'm curious, Natalie, do you mind? I saw that you have an inhaler there, just kind of showing it real quickly how easy it is and how fast it is, and really how discreet, because you can just keep it in your pocket and do it really quickly.
Absolutely. So there is a cartridge, which I don't have in front of me actually, a tiny cartridge that just sets into this
Yeah.
into the inhaled device. You click it closed. They're color coded so that you don't when you reach into your refrigerator where you store unused cartridges, right? You can take the ones with you that you're using for the day that are color coded for 4, 8, or 12 units. Remember that they're not that high of a dose. You put it in, you click it, and then you just insert and inhale slowly. Now, a couple of things. When we first started using inhaled insulin years and years ago, there was not really education around it, right? I was handed one of these and said, go try it. And now what we know is take a sip of water, then use the so that it clears anything in your throat that might cause a cough. And a longer, slow inhale is better than a quick inhale. So we're not trying to do this isn't asthma rescue, right? I think about it that way. This is not asthma rescue. This is really trying to get that drug consistency into the lungs. So it's versus that, right? So I think that's one of the things that really does so the big side effect of this medication in the inhalation phase is cough. So if you do it wrong, you're going to get a cough. If you try to blow all of this, it's going to hit the back of your throat. But if you're inhaling it, it won't. So we have found because we have samples in the office and because we have practice ones of these in every desk in our office, in every exam room, we pull it out, we demonstrate it, and I think we have higher success rates when we do that. So for those listeners out there or viewers, we want to make sure that you do it correctly and that you're taught how to use it correctly.
Yeah, there's also we have this Blue Hale and a device as well that it actually it kind of records how that inhalation is and then makes sure that it is strong enough. And I think once you learn how to do it kind of that right way of how to inhale, then it's like you just know it. And so you don't need to keep reusing that Blue Hale. But I think it helps for learning
For
how to use
teaching,
it in the
right,
office.
absolutely, and think about it this way, right? When you had to learn to give insulin, the first thing you did was, put the needle on if you were using a pen, stuck it in, pushed the button, and took it out, and we're like, "Wait, you need to wait 6 seconds, hold it in there, give that insulin a chance to settle." It's the same thing with this, right? There's a tiny bit of technique, not difficult technique, don't be afraid of this, but there is a little bit of a technique, so then when you get it right, then you can actually experience the best of all of it.
For
The other
sure.
I think we should talk about is the fact that you need to do an FEV1 before you start this product, right? We need to
Yeah.
make sure your lung function is good enough to use it. So you can't use it if you have COPD. You can't use it if you're a smoker, right? But the majority of people, have no problems with this. So we actually do the machine. The FEV looks like this. Does yours at your practice does too? So these
It
are
does too. We have a few different versions with different color, but it
we
looks
do too.
essentially the same
We have a
size.
larger blue one, we have whatever, and the beautiful thing about this is because these pieces, this is the part that your mouth goes on, these pieces are completely disposable, and we do have some of them provided by Mankind right in our office, so I don't even charge for that. So they need an FEV1 before they initiate, right? And then yearly thereafter. So, we can do it right in the office. So what is an FEV1? It's going to measure that lung capacity. Can my lungs take this? So what we do is we turn the device on and and we have the person take a very, very deep breath. And then we put your lips on it and say, blow, 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 blow as hard and as like empty your lungs as hard as and fast as you can. We get the measurement and then we say, you're good to go. Right. So we used to have to send them to pulmonology and do this whole thing, and it's all gone. We can do it all in the office and get someone started that very same day.
Yeah, I also just want to add that in the cases of like where I'm seeing someone virtually, like I have this some people that live in Florida and that's where they are in the winter, but then they come back here in the summer, but we don't want to wait until the summer to be able to start inhaled insulin. So we've actually been able, the company's been able to mail them this FEV1 machine. And so it's been really straightforward through a virtual visit. I've been able to counsel someone to blow into it. We usually do 3 because the first time they're like getting used to it, right? And then that third one is like the best. And then, yeah, it's 6 months, we do it again. And then it's just every
Yeah.
year after that. And it's really just to make sure someone didn't develop asthma, COPD, something that could affect their lungs. So, but it's a really simple, straightforward process. That's usually needed to get the insulin. So in terms of, cost, access, coverage, that's always something that comes up. I found so with Medicare, they do have where you've got the $35 insulin. And so often what is required is that you may need to do a prior authorization showing why kind of the original insulin, whether it was Aspart or Lispro, kind of why we want to try something different. And often we say, well, we want a faster acting insulin, something that is going to someone doesn't have to pre-bolus as much and is going to bring a high glucose down much more quickly, and also the ease of use. And then we can get that covered for $35 on the Medicare plans. And then there's copay cards for the commercial insurance as well. So often we're able to get this covered. It's just usually it's a prior authorization.
Yeah, and I would say that the other side of the Medicare part is, of course, what is that you can say we need postprandial glucose excursions. That's what this drug addresses, right? It is a
Yeah.
rapid acting insulin. So if you can say that they have, that, yeah, I mean, think about this, you guys. If you're too high 2 hours after every meal, that's 6 hours a day that your time is above range, right? And that's a lot of time. So if I can use a more rapid acting insulin, I'm afraid of pre-bolusing. I pre-bolused once and then I had a low. And I had a low at a restaurant and it was bad and my spouse got upset or something happened or whatever. I'm never doing it again. And so then people pre-bolus right before they eat and we see these spikes. I mean, I talk about pre-bolusing every day with lots of my patients, right? So we can usually demonstrate that without a problem, right? These people are typically on a CGM because they're on insulin with Medicare. And so it's covered, right? And so we can say they are spending time above range postprandially, and that's why we need that faster acting mealtime coverage. And it's a 2 sentence prior auth. It doesn't take much, right? We attach the note and we're done.
Right. Yeah, I agree. And there's also, in case someone doesn't have any coverage for it, there is a cash pay option, which ends up being $99 a month if it's just totally declined by all of the insurance. So I feel like there's ways that this can be accessed. And it's also not all or nothing. So I have some patients that choose to use this for all of their fast acting insulin. But then I have others that choose to use this for times where it's really difficult to pre-bolus, for times to bring down a high glucose. And I want to talk a little bit more about that because with traditional insulin, like with Aspart or Lispro or glucosine, with those insulins, we have to be really careful about taking more. Because you can get into a situation called stacking, where let's say you just took some, it's 2 hours later, you're high, you want to bring it down. Well, it's not necessarily safe to do that with those other insulins because it's still working in your system. And if you take more, then you risk ending up getting too much and experiencing a low, especially if you're not using a pump. At least a pump kind of tracks this active insulin. But if you're doing injections, gosh, it's just, we usually tell people just wait 4 hours. But that kind of stinks. You telling someone you got to wait 4 hours, they're hitting 300, and
And
you're
they're
just having to
watching. I'm
wait.
289. I'm 262. I feel miserable. I feel defeated. I feel like it's so emotionally hard to be high for that long, right? Like I absolutely agree with you. There's a very good friend of a mutual friend of ours, a physician who is out in Oregon, Eden Miller, is like, I use it as a rescue drug. And that's how she presents it. A very good friend of ours out in Oregon, Dr. Eden Miller, says that she uses inhaled insulin as the rescue. So she uses glucagon as a hypo rescue, and she uses inhaled insulin as the hyper rescue. So that we can actually say to somebody, you can use this to fix extreme highs. Your pump site fell out, your insulin went bad, your something else happened, and you can use this to bring yourself down quickly. And not that it's the only use by any stretch, but I love that concept when we talked about that. It was maybe a year or so ago at ADA, we were talking about that with her. I love the
Yeah,
idea.
I know, I love it. It's like the glucagon of treating hyperglycemia,
Right.
and I think the important thing is that we're just proactive about it, that we can let people know, "Hey, if you gave a dose and an hour later you're above your target, you're high, you can it is actually safe to give more." In fact, there's guidance, like, you can do another 4-unit cartridge, depending what your level is. You may be able to do 8, so we can give people guidance, so it is safe an hour, 2 hours, so they're not just waiting, and in fact, the people that do the best on it are proactively doing that. They're wearing a continuous glucose monitor, they're looking at their glucose, they're getting an alert if it is high, and they're not afraid to just go ahead and inhale a little bit more.
Yep, I think it's a great option, and it really is, I think the biggest thing is it's underutilized because we could do that, right? I mean, we really can. So I am truly encouraging people to consider it and making sure that we make it easy. We have it set up in the office now where the process doesn't, we're not adding 45 minutes to a visit. We're not saying you're never going to get out of here. It's much more of a we can do this test. We actually have samples in our office. So we can offer you a sample if you want. This is how you need to use to blow. You can use you can use the system, get going, practice one time and get out the door, right? And that's also part of it, right? Is that it should not feel like, oh, this is going to take another 45 minutes of my time. Is it worth it? It really does become worth it. People who are using it are very happy.
Yeah. So I think the bottom line is we just want you all to know that this is an option. It's another option of insulin delivery. We are all about knowing the different options and being able to pick what works best for you. With that, we thank you so much for tuning in. And that wraps up this episode about inhaled insulin for diabetes sisters.